Dear colleagues, ladies and gentlemen, following on the C19 skills preparation course, I'm delighted to introduce Professor Jos Lasthour, that we all know from both ESICM and ESTNIC. Professor Lasthour has a worldwide reputation in clinical nursing. He is professor in clinical nursing at Plymouth, at the University of Plymouth, but also professor of pediatric nursing at Yunnan Children's Hospital. And his name is very well known, and I think he is exactly the right person to address today the topic of well-being, coping strategies, and teamwork in this very specific setting of the COVID-19 pandemic with a critical care view. Thank you very much, Jos. I'm delighted to introduce you at this symposium.
Well, thank you very much, Professor Elia Azoulay, for inviting me and introducing me for the kind introduction. I'm really pleased to be invited in the C19 space program by the ESICM and funded by the European Union. I've been working in intensive care for over 30 years, and well-being in coping strategies and teamwork has been on my radar for some time. This session is actually related to the two learning outcomes I defined, which is to describe the impact of COVID-19 on staff well-being and what coping strategies are used by staff to stay healthy, as well as to identify interventions to enhance staff well-being during COVID-19 pandemic and to create a positive teamwork climate between healthcare professionals not regularly working in the ICU and those working in the ICU. Now, these are massive learning outcomes. In order to structure this session, I actually have two questions. The first question is, and I'd like to debate it with you, what do we know now at this point and the first sort of period of COVID-19, and what should we do now based on what we know now? So if I'm really invited the participants to go to the ISICM website, where all the resources, what we know now, are available, freely available, and it's important to have a look at it. So the first question, what do we know now, is to understand how COVID-19 has impacted on ICU staff well-being. And I'm happy to debate that part of the literature, part of the knowledge what we currently have. And there's a massive numbers of studies has been done, and perhaps one of you have, and maybe many of you might have been invited to participate in survey studies, just to understand for what this impact has on our staff. In order to sort of start somewhere, I think it's good to go back to China, where it all happens in Wuhan, when Wuhan was struggling to cope with the massive increase of patients in the ICU by COVID-infected patients. Now, I'm really pleased to share with you our study, because I'm partly working in China as well. Professor Zhang, Yusha Zhang, and I, we have created at the early onset of COVID, back in January, February, a study among nurses who were deployed from the Zhongshan Hospital in Shanghai to Wuhan to work clinically in Wuhan there. Now, the aim of this study was actually to understand, particularly this early onset staff experience of COVID, to see what the stress, burnout, and coping strategies were of these nurses. You can see the group is a fairly young group of nurses, below 30 years of age, with 66%, obviously limited experiences if they were all young. They were all caring for severe and critically ill COVID-19 patients. And during the study, from the onset of the study, they had at least 1 month experience in the COVID unit. In order to understand the outcome measures, we created, or adapted actually, a survey from the SARS epidemic that has been published. And we adapted a few of the questions towards the COVID-19 situation. Now, what kind of perceived stresses have we identified? And there are mainly three of them. 85% of all the nurses said that uncertainty how long the current situation status will last was a stress factor. The 84% thought worrying to get infected was important as a stressor, and 76% discomfort caused by protective equipment. Furthermore, looking at the analysis, we found that nurses with a younger age, with less working experience and longer working time in COVID-19 units, had a higher burnout levels, which were actually measured at burnout levels by the Maslow burnout scale. And one of the scales was the emotional exhaustion domain, which causes really stress levels and burnout levels with the nurses. Now, this is China, but actually, I believe we need to go back to what we know about our culture here in China, in Europe. And I'd like to address a few of the papers and the evidence coming out from Europe. To start with, Germany, the country, smaller study here, including only 75 nurses and 35 physicians. The aim of this study was the psychological burden of healthcare professionals at time of COVID. Survey study. One of the questions in that survey was, what is at the moment your biggest burden? And as you can see, job strain, uncertainty, and care for people have been the most three highest priorities in terms of burden given by these nurses and physicians. The other question I'd like to sort of address is, what would help you the most at the moment? And that is actually the infrastructure. Now, what is based on what has been defined infrastructure in this survey is insufficient staff. So what is the staff level? Do we have enough staff? Is there a clear organization? Was there a clear planning of the COVID patients into the hospitals? And that is really what would people help in coping with the current situation in Germany in this study. A larger study from Germany, including 3,669 healthcare workers, of which most were nurses, doctors, and allied health professions, identified actually that healthcare workers who work in the COVID units, such as ICU, emergency, COVID wards, reported higher levels of burden and stress. Nurses had higher ratings of burden and stress than doctors and other staff, and overall healthcare workers had high scores of agreement with the measures taken by the hospital. So depending on what kind of actions has been taken by the hospitals, most of the healthcare workers thought that were really good guidelines and protocols that has been installed. Interestingly, already as a warning here in this study, is that nurses had a higher rating of burden and stress. In another study, I'll come back in a minute, it's the way around, where doctors actually reported a higher burden and stress. For example, here in this study in Spain. In Spain, another study with the aim of looking at and identifying compassion fatigue, burnout, compassion satisfaction, and perceived stress in healthcare professions. A fairly good-sized sample size, 506 participants. The outcome measures this research group used was the professional quality of life scale and the perceived stressor scale, including 14 items. Now, the professional quality of life scale has actually three domains. So one domain is compassion fatigue, the second domain is the burnout, and the third domain is related to compassion satisfaction. Now, as I said already, compared to the previous study in Germany, here, in contrast, doctors had a higher compassion fatigue and burnout than the nurses, while nurses had a higher compassion satisfaction rate in terms of burnout and fatigue. The perceived stressor scores were the same in both groups. And I think Italy is another country where we need to look at a study that has been presented and published recently with 145 participants. What is good to see in this study is that the sample size has been divided in two groups: COVID wards, those working in the COVID wards, and those working in other wards. So those working in COVID units had higher post-traumatic stress syndromes and depression. And the good thing is they look at some predictors of stresses and depression, and they found out that female and modern relationship is associated with higher levels of depression, as well as being a female healthcare worker in the older ages. It's associated with higher levels of post-traumatic stress syndromes. Now, the last paper I like to sort of debate in Europe, from Europe, is the paper from Elia Azoulay and his team from France. Fairly large sample size, 1,058. And again, similar like the Chinese paper, it's a fairly young sample size here with a median age of 33. The majority were women, and the majority were nursing staff. And obviously, the outcome of this paper, looking at anxiety, depression, and peritraumatic dissociations, were that the prevalence of anxiety was 50% among the respondents, depression was 30% among the respondents, and peritraumatic dissociation 32%. What makes this paper really important for us, and this lecture actually looking at coping strategies, coping mechanisms from those staff members who have experienced the first COVID-19 wave, is that this paper was able to identify 6 modifiable factors of mental health symptoms. So one is fear of being infected, the inability to rest, the inability to care for family, struggling with difficult emotions, restrictions in visitation policies, and all about hasty end-of-life decisions, so being part of that. I think what is important by this paper is when we read the modifiable factors and looking at coping strategies, these are the knowledge we should have in order to identify and implement interventions to guide and support all healthcare professionals, the new ones, the new coming into the ICU, or even those who have been working in ICU for many years. So basically, what do we know now is that to understand how COVID-19 has influenced, we need to look also at the coping strategies. So there's a few papers out there I like to discuss about coping strategies, what we know now of healthcare staff. How do they really cope with the COVID-19 situation in the ICU? In that case, I'd like to go back to our old paper where we actually presented the 107 nurses a list of 17 identified coping strategies in the literature based on the SARS epidemic. Now, this is what you can see at the table 3 with a list of items. And there were 2 questions. One was is this a strategy you're actually using? And how often, how frequent are you using this strategy? So the first was taking preventive measures. Obviously, all 107 have done this as a sort of coping strategy to stay safe, to stay healthy. And on the mean scale of 0 to 3, from almost never till 3, almost always doing this. These nurses rated almost like all doing it constantly. The other coping strategies are actively learning about COVID-19 is a really good way forward. It helps to reduce stress levels. Actively learning professional knowledge. So this is particularly important because these group are actually non-intensive care nurses, and they thought they really needed to found that it's really important to learn about intensive care background, how to deal with intensive care patients, how to deal with the mechanical ventilations. Can we learn as quickly as possible how to arrange the care of a patient on the ECMO? So this is really what this group of nurses would say. Increasing professional knowledge is really important as a corporate strategy to stay healthy actually during this COVID-19 pandemic in the ICU. Adjusting the attitude and facing the COVID-19 positively is important. Chatting with families and friends, for them it's really important. And creational activities like music, sports, safari, etc. Now, safari is a bit of an odd laughing thing in the fresh air, but safari is also giving a walk in the woods, in the fields, in everything. That's a safari. The other paper I like to share with you is the paper of Aziz and colleagues, which is published in Intensive Care Medicine recently. This is actually a paper managing ICU search during COVID-19 crisis and rapid guidelines. The importance of this paper related to well-being and coping strategies is that this group of authors look at the literature, same what I just presented, what has been known so far in the literature from staff members in ICU during the COVID pandemic. And what do we know so far is this whole list of coping strategies, from sense of duty to country to the community. So we think it's important that sense of duty is a sort of strategy to keep us living and working during the COVID pandemic. Peer and family support is important. Social media platforms, WhatsApp has been used a lot to share our knowledge. So using WhatsApp, giving actually WhatsApp and time to sort of use WhatsApp with family, with colleagues while in the unit and working. That's fine. Religion has been mentioned as a coping strategy, following PPE precautions, learning about COVID. So all these factors, what has been listed here, has been identified in the literature and could be considered as a strategy once we go back into the intervention mode and how can we best support all staff members during COVID. So what do we know now? The conclusion so far, with all the survey studies, with all the studies where we gain a lot of knowledge over the last 6 months, is that caring for COVID-19 patients in the ICU can negatively influence the well-being of all healthcare workers. That means for me, it's like all healthcare professionals, so nurses, doctors, allied health professionals, dietitians, cleaners, anyone working in the ICU, but also those coming from other units who have been deployed to go to the ICU to help the ICU staff in caring. Because yes, here in the UK, we've been asked to go in and just help, even if we don't have ICU knowledge, we would be able to help to turn a patient from to prone position, for example. These little helping attitudes and actions, this is fine, but it really influences our well-being possibly. Healthcare professionals use a wide range of coping strategies to survive actually COVID-19. So this is what we know so far. But what should we do now? What should we do? So the learning outcome of this session, the next half an hour, or next 15 minutes, is to identify interventions to improve staff well-being and to explore factors contributing to a positive teamwork climate between those healthcare professionals not regularly working in ICU and in ICU healthcare professionals. Again, watch this space on the SIGINT website. All the sort of interventions will be listed. Yeah. Now, a good paper in critical care. Back to China again, I must admit. A paper that described fairly early in the onset of COVID-19 pandemic is that there were 85 nurses working in the ICU mostly young nurses with limited experience. However, they actually experience what we are experiencing as well here in Europe, that we need to have a good understanding how to improve the well-being and safety for the staff in a new ICU team, because we now have an issue where the new ICU team is staff working in the ICU, including all staff who are deployed to our ICU to come in and help. The good thing is that they have a really nice paper describing their 8 sort of strategies, what they actually sort of suggest to do. So here are the first 4. A psychologist in the team is really important. Work on a harmonious working environment, because that definitely we have the evidence that that will relieve and reduce stress. That try to sort of promote the expression of your emotions, talk to people, sing, and ask them how they feel, and communicate with colleagues as much as possible, and particularly those with the same experience. The other 4 experiences they have is that they created small groups with a team leader in order to communicate with them via WeChat. That's a similar app feature on the mobile as WhatsApp, mainly used in China. That enhance actually teamwork, atmosphere, and cohesion. Regular meetings are advised to organize that, particularly, I would say, with a professional consultation team related to mental health professionals such as a psychologist or a psychiatrist. And don't forget actually that the social support system that is linked with the family members at home is really important. So these are the sort of 8 interventions they have sort of described in this paper in order to safeguard the staff well-being. To make it even more visible what kind of solutions they have done is, for example, lack of work experience in infectious disease. So that is what they experience of staff coming in to help in the ICU. So they allocated appropriate patients according to the actual nursing ability. It's actually the nursing knowledge. What kind of level of ICU knowledge of the level of acuity of the patients, try to align them. So if I have a less severe ICU patient, you might assign nurses coming in with limited ICU experiences to assign care to these patients instead of complex intensive care patients on ECMO, leave them to the ICU team, more experienced team members to take care of. For example, worried about getting infected, that is, everybody's worried about it. Enhanced education and training, that's a solution that should be given. There is a huge workload. It can't be underestimated that the workload is tremendous during COVID in the ICU. And there's some concern about long-term fatigue. They advise actually to adjust their shift work. So don't allow and even send nurses and staff members and doctors out of the ICU if you think they are there for too many hours already. You need to have regular breaks. Now, coming to interventions, really basic, really more practical. So coming back to the more interventions, very, very pragmatically. What can you do as an individual? What can you do as a peer-to-peer? Start becoming aware of the safe working climate by sort of installing regular breaks. Step out and take an unscheduled break. You're allowed to do that. So even if you're not used to an ICU environment as a new staff member coming in the ICU and you think I need a break, I just need to go out. Allow yourself to go out and allow yourself to time during the shifts to recover. Talk to your colleagues, find a buddy is important. Express your feelings. Everybody is different. So also try to identify the feelings of others to support. In terms of teams, if you look at teams, I think it's really important that there's a synergy between the staff working in ICU and the staff coming in to help who are deployed from other wards coming into ICU environments. I think there should be a very welcoming environment. So you need to welcome staff and make them feel safe and valued. I think we should respect individuality, schedule time to check on each other's well-being, and by the end of the shift, find a personal debrief, organize that, and ask people and support them how this shift was. Weekly team and staff well-being meetings, even on online platforms, and be flexible as a person within the team, but also as a team. Be flexible in the sense of if somebody does not want to come along or want to sit in one of the meetings, that's fine. Respect it. It's fine to be excluded. It's fine to go home and not staying for another 5 minutes for a final debrief. What to do by managers? I think it's important to address a few of the interventions that needs to be at least supported by team leaders in the ICU. Staff huddles. There is enough evidence out there that staff huddles at the beginning or the end of the staff or even midway boost communication. And that gives you the option actually to sense the emotion of the staff if you do so. Buddy system, pay attention to the new staff coming in the ICU. Peer support conversations. Be visible, approachable as a manager or as a team leader, because people are watching the team leaders, they ask for advice. Follow up at sick leave is really important, and organize, if possible, mediation and mindfulness sessions. Now, we have quite a number of very nice abbreviations in intensive care environments. So but I think this one is really nice to sort of remember. It's easy to remember. Face covered, which means focus on what's in your control. Acknowledge your thoughts and feelings. Don't push them away. See, come back into your own body. Just be yourself. Don't pretend to be better or be brave. Be yourself. Be engaged in what you're doing. Really try to stay engaged, even as hard as it is sometimes. And then the COVID abbreviations: committed action, opening up, values, identify resources, and as we all learn, disinfect and distance. So it's if I would have sort of an advice in sort of what kind of interventions and how should I work when I go to an ICU where I don't know actually the rules and regulations, the protocols, the guidelines. Keep face covered in mind, and all the staff members will help you. Sorry. Just as a sort of practical example, this is published in Pediatric Critical Care Medicine, where the pediatric intensive care unit actually did describe some well-being initiatives. So make space safe was one of the initiatives. The communal staff room that was usually lined with clinical information, they would say probably never read. Imagine going to the staff room, how many sheets are hanging on the wall, you never read, and actually they change it, they make it more friendly, just to sort of provide staff downtime. Support with tea breaks as much as possible. It's not only the tea breaks, so really reallocating the tea room vending machines to the staff rooms, so you don't need to walk away, far away to get at least something you want to have for your tea. And water, it's very simple. The large water filters or canisters to have cold water everywhere across the ICU. I think about 10, 15 years ago when I was a manager at the ICU, when I bought these water filters, I think that was the best ever I did for my team, because the team really hallelujah this intervention. Reinforcing the positive, like they did, they sort of put laminated wool stickers that people could write on the leaves of the tree some really good messages. So they have a positive tree in the staff room to write down good messages. Maintaining that team feeling is really important. To give especially the PSU team badge to every staff member. Now, one of the final interventions I'd like to discuss, and just briefly highlight them because it takes a bit of work to organize, is the Schwartz round. They become very famous, they become very, very effective. So what is a Schwartz round? It's a group reflective practice forums giving staff from all disciplines, an opportunity really to reflect on the emotional and social aspects of working in healthcare. So bringing that back to the unit, in my own practice, we use Schwartz round like 4 times a year, debating in the ICU emotional, practical, or social aspects. So in this case, we've done it recently with the COVID. What is the impact on COVID has on myself? So we share our feelings and we have the whole multidisciplinary team around the table. I'll add with you on the slide the Schwartz Center .org, and the most recent about COVID is presented and freely available to download. So what should we do now? In conclusion, I think that well-being of ICU staff during COVID-19 is important for those not regularly working in ICUs and those working already for a long time in ICUs. And I think that teamwork is a driver for surviving the COVID-19 pandemic, because teamwork optimizes our patient outcomes, family satisfaction, and definitely staff well-being. There's a however. Just simply remember this one liner. Simply remember it is okay not to be okay.
Feeling like a drop in the ocean that don't nobody notice. Maybe it's all just in your head. Feeling like you're trapped in your own skin, and now your body's frozen. Broken down, you've got nothing left. When you're high on emotion and you're losing your focus and you feel too exhausted to pray, don't get lost in the moment or give up when you're closest. All you need is somebody to say it's okay not to be okay. It's okay not to be okay. When you're down and you feel ashamed, it's okay not to be okay.
Well, thank you very much for your attention, and I wish you good luck, and I really, really hope you to stay safe. Thank you.
This is with my mic. Thank you very much, Prof. Latour, for this amazing presentation. Not only that presents important data, but also summarizes very well what are the different options, the different opportunities that we have to build resilience, short and for longer time outcomes. And I appreciate, I learned a lot, and I appreciate very much your presentation. May I ask you 2 very short questions? One is about the vulnerability. We know that based on the data that you report and the clinical experience that we have in the ICU, that not everyone is at the same level. So do you think that there are, based on your clinical experience, elements to strive for people in the team that would need to be more into the groups you mentioned, or the intervention that could include mindfulness or team building or any other opportunities to improve? Or do you think that this is really for everyone, and then how you would organize it?
Thank you very much, Ailey, for this sort of very practical question. we do need to acknowledge that stress levels are high, and particularly during the COVID time, where everyone is busy, I think personally, I think mindfulness training is important to provide. But my fear is a bit that if I talk to my colleagues in clinical practice, they simply want to go home. They simply want to talk to family members. So what I experience is in the last 6 months mainly, and talking to colleagues in the field, is that they really are happy to go home after a long shift and be back with the family members. However, I must admit that providing online training maybe, or a mindfulness training away from the hospital, because that is important, to get it away from the hospital, might help them or might benefit actually this little small group that might be coming into the need for additional help.
Thank you. Thank you. There is another point that I found very interesting, not on your slide and with the way you presented it. It's about the variability across countries and across cultures. And there's a common point, at least in the countries I know, where clinicians were very much engaged into COVID-19 care. But at the same time, we had the feeling that family members and the lay public applauded. And my question is, as we care for the patient, would you see any intervention from the family members towards us to improve ourselves and to help us build resilience and cope with the burden of managing the patients? And this exists in some cultures. I would like to know your perspective.
Yeah, I'm really pleased you say and address this. Really, for me, the most important issue. What has been forgotten in many papers, or even in the science, in the studies, is the impact of the family members, of staff members at home. So, and we have not thought about how to sort of prepare or guide, or I wouldn't like to use the word education, but provide information how family members can support staff members at home. As an example, I'll have a 12-hour shift, I'm exhausted, I'm driving home, I come home, and guess what? I have a fight at home because my family members simply said the wrong thing at the wrong time, and I'm exhausted, and so there's a fight. You want tensions at home, in the family at home. So I think this is one thing. We need to think ahead, and how do we support family members of ICU staff at home, so that at home at least there's a safe environment. Because if I don't feel safe, or if I have clashes or big fights at home, and you want me to come back to work the next day, I might feel different. Now that is one thing. If you continue looking at that across cultures, from my experience in China, particularly in the early months, while having lots of debates with the staff, and I asked them this question: how are you coping? Because those nurses were deployed to Wuhan, away from their family members for 3 months. Now that is where they say, this is where the social connection is really important, where I would say that the WhatsApp and the WeChat groups are important to sort of have, but allow actually in between long shifts that staff members can go back to the family. sorry for a long answer, but I think it's so important because we have not addressed that at all as healthcare professionals. We nurses, we doctors, we think about ourselves to make sure our resilience is fine and we can cope with the situation. But I think the 12 hours at home with our family, that needs a bit more attention.
Thank you very much, and I learned a lot. Your perspective is really amazing. I was very, very pleased by your presentation. And thank you all. And next move to the next presentation. Thank you.
Thank you.